Hi everyone, my name is Mia Harris. I did my case presentation on polycythemia. Polycythemia is a blood disorder in which there is an increased production of erythrocytes, the red blood cells, and other cells such as the granulocytes and the thrombocytes in the bone marrow. The increased proliferation of blood cells increases the blood volume and viscosity, the thickness of the blood. When this happens, the blood vessels become distended and the blood flow is sluggish. This leads to frequent thrombosis, which are blood clots, and infarction, decreased blood flow to the organs throughout the body, especially when the platelet level is elevated. Polycythemia is one of the various neoplastic blood disorders that is caused by genetic mutation that can develop over a lifetime. So the case study here is Mr. Casey. He's a 45-year-old single male construction worker who lives alone. He has a history of testicular cancer that was treated 5 years ago. For the past week, Mr. Casey has been experiencing chest pain, fatigue, shortness of breath with little activity, and has also been unable to work as well. He also noticed some bleeding after brushing his teeth, so he goes to the ER. Mr. Casey was seen by the ER physician, and he also mentioned additional symptoms which are listed here: headache, blurred vision, pruritus, numbness in the hands and feet, and then the chest pain, shortness of breath, fatigue, and the bleeding of the gum. Physical exam findings. So upon physical assessment, the following clinical presentations were noted. Mr. Casey was plethoric and cyanotic, which means that he appears to be swollen with deep bluish red skin and mucous membrane, and this is due to the engorged blood vessels and sluggish blood flow. He also had a high blood pressure. There was pain in his big right toe, and it was swollen. He also had a flushed skin. The face and the hands were also flushed as well. Diagnostic testing that could be ordered. So some diagnostic tests that was ordered for Mr. Casey was the MRI to view the organs and the bones in the body. So the MRI results showed hepatomegaly and splenomegaly, which is just enlargement of the liver and the spleen. There was also gout noted on the MRI as well. Gout is the result of uric acid accumulation in the joint tissue of the big toe. The CBC was done to test for the blood cell count, and as you can see here, all the blood cells were elevated. The hematocrit elevated, red blood cells, hemoglobin, platelet, white blood cells, all were extremely elevated. The serum erythropoietin level was 0, and I will get into that later. The JAK2 mutation analysis was positive. I will explain that later as well. And hyperuricemia was also noted, which is high level of uric acid in the blood due to the high cell destruction rate. So based on all of this, we can say that Mr. Casey is diagnosed with polycythemia. For starter, he presents with the subjective symptoms, which are shortness of breath, headache, blurred vision, fatigue, pruritus, chest pain, numbness in the extremities, and these are all indicative of poor perfusion due to the viscosity of the blood. So his labs, the CBC, were all extremely elevated, which is due to increased blood cell production and blood volume. The serum erythropoietin level was undetected. Erythropoietin is an enzyme produced by the kidney to stimulate the production of red blood cells, the erythrocytes in the bone marrow, in response to tissue hypoxia. So in the case of Mr. Casey, there is no need for the kidney to produce erythropoietin, since there is already an increase in the red blood cells, as seen with polycythemia. He also tested positive for the JAK2 mutation analysis. So the JAK2 is a non-receptive tyrosine kinase. is an enzyme that phosphorylates protein. So the JAK2 enzyme is found in the bone marrow and controls the production of blood cells, the red blood cells, white blood cells, and platelets. So mutation of the JAK2 gene can lead to the production of too many blood cells, leading to neoplastic blood disorders such as polycythemia. So splenomegaly is also present in patients with polycythemia, as noted on the X-ray for Mr. Casey. So the spleen filters old blood products from the body. So with splenomegaly is present with polycythemia because the spleen is working very hard to filter the heavy blood volume. So the spleen will increase in size. Hepatomegaly is also present in patients with polycythemia due to portal hypertension. Portal hypertension occurs when resistance to portal blood flow increases. The resistance often occurs in the liver, which is the reason for the hepatomegaly. Gout is also present due to excessive uric acid accumulation in the joint tissue of the big toe. So uric acid is produced, as I already mentioned, as a byproduct for the cell breakdown, and this is seen with proliferation of the blood cells. So how is polycythemia treated? The first treatment is the therapeutic phlebotomy, removal of blood to decrease the blood volume and minimize the possibility of thrombosis or hemorrhage. Next, we have medications and radiation, which are used to suppress the activity of the bone marrow. With this, there is an increased risk of leukemia, increased number of immature leukocytes or fibrosis, which are thickening of the connective tissue. Hydroxyurea is a medication. It's an oral chemotherapy medication that is used to suppress the production of white blood cells and platelet. Interferon alpha is also given as a subcutaneous injection to reduce the red blood cell count. It also reduces the size of the spleen and relieves the pruritus, the itching, that is most likely caused by jaundice due to the hepatomegaly. Busulfan is given when hydroxyurea and interferon has failed. So it is also a chemotherapeutic agent that keeps the white blood cell and platelet count at an acceptable range. This medication has fallen out of favor due to the side effects of low blood count, pulmonary fibrosis, and hyperpigmentation. The last medication here, this pronunciation is terrible, the ruxolitinib, I'm sorry for that. It is given to inhibit the JAK2 enzyme, which is defective in polycythemia. Alright, so that's that. I encourage you to please print out the note and just read it, and sorry for my accent. And these are my references, and thank you for listening. Okay, bye.